I'm going to be talking about treatment of primary hyperpara and how it relates to fracture risk. So as we all know, primary hyperpara is one of the most common cause of hypercalcemia, and the estimated prevalence in the US is about 1 to 1,000. And we saw this graph this week, and it just shows the natural history of bone density in patients that are not treated with primary hyperpara. And we can see that there's loss in bone density in the femoral neck and the radius. So there's a concern that this might lead to osteoporosis and elevated fracture risk. And we all know that surgery is the only definite treatment for primary hyperpara. And on that same observational study from the prior slide, they also followed patients that underwent surgery, and they noted there was improvement in lumbar spine, femoral neck, and radius. And I just want to note that there was improvement in all sides, because I'm going to be talking about a different study that showed something a little bit different. And so we see that this the study, they followed patients for about 15 years, so we know that this improvement is actually sustained. And what about sort of fracture risk and how it relates to surgery? There are some retrospective studies that they show that there is some improvement in fracture-free survival. This was a retrospective cohort that had about 500 patients that then noted there was a decrease in 13% in terms of 10-year fracture-free survival in patients that underwent surgery compared to patients that was just followed by observation. And what about medical treatment? So we have the bisphosphonates, and this was a study done here at Columbia that was a double-blinded, placebo-controlled study that compared patients that received alendronate for 12 months, and the control group received placebo. And on the second year, they all went into alendronate. And then we can see that there's improvement in the lumbar spine, and also in the total hip, although for total hip, the improvement was mostly on the first year. And I think the question that we also heard was that, and how does this relate to fracture risk? And as far as I know, there wasn't any study until probably this study that just came out recently at the Annals of Internal Medicine. And the study was looking at the relationship of parathyroidectomy and bisphosphonates with fracture risk in primary hyperpara. So I'm going to be just going over the sort of methods and results of this study. So the objective of the studies were to examine the BMD changes and fracture rates among patients with primary hyperpara that were managed with surgery, bisphosphonates, or observation. So this was a retrospective cohort study. It was done at Kaiser in SoCal, so they have access to this really large data set. At Kaiser. So the participants, they were defined biochemically as primary hyperpara, and they looked at patients from 1995 until 2010. So it's a pretty sort of large, extended time. And their diagnosis of primary hyperpara was defined as a serum calcium more than 10.5 and PTH more than 65. And they excluded patients that were just member of the Kaiser insurance for less than 6 months. They excluded patients that were young, less than 20 years old. And they also excluded patients that had creatinine more than 2.5. And the thought is that they would be excluding patients with renal secondary hyperpara. And they also excluded patients that had 2 or more tests for immunosuppressant levels. And their thought was that they probably would be excluding patients that had kidney transplant with a possible tertiary hyperpara. They also excluded patients with history of breast cancer, history of bisphosphonate treatment, and patients that had an incomplete course of bisphosphonates, which they defined as duration of less than 1 year. So the definition of parathyroidectomy, it was by ICD-9 code and also by procedure codes. In terms of bisphosphonate use, it was a pharmacy database that they have access to, and the time that they were taking bisphosphonates was defined by the first and last dispensation date at pharmacy. And it's noted that there are patients that they might have had both medical and surgical treatment. So for patients that had that, they assigned those patients to the initial treatment, and after that, those patients was censored at the receipt of the second treatment. So I think it's important to know that they actually don't mention how many patients were censored, but then there's a part of the patients that actually censored off the study. And in terms of BMD, they had only total hip and lumbar spine, and so they didn't do the sort of distal radius, was not routinely assessed. And in terms of fracture outcomes, they defined that also by ICD-9 code. And I think it's important to know that they divided by hip and non-hip. And on the non-hip, as you can imagine, it included a lot of things. It was like vertebral, scapula, there was like ribs, tibia, like patella. So that's all lumped into non-hip. So in terms of statistical analysis, in terms of the BMD, they were studied over sort of 4 periods, from 0 to 2, 2 to 5, 5 to 8, and beyond 8 years. And they compared the follow-up BMD to the baseline, and they adjusted for age, ethnicity, and they used this Charlson Comorbidity Index score, which is a score that predicts fragility fracture in elderly patients or patients that had other medical conditions. And they analyzed fractures in terms of time-dependent Cox proportional Hazard model, which they know that this same group had published other data before, but they didn't use a time-dependent model before. And they did a bunch of secondary analysis, sort of fancy stuff to control for which treatment group each of them got, and for the study not being non-randomized. So they just tried to control for everything. And they also tried to control for if you meet surgical criteria for treatment or not. They also control for that in their analysis. So going to the results of the study, I think that's the most interesting part. So they had a pretty large cohort, and I think that's one of the sort of interesting thing about the study. They had total almost more than 6,000 patients, and you can see that about 55% of the patients, they were followed for observation, and then about 20% they were on bisphosphonates, and then 20% they had parathyroidectomy. So, you can see that, most of them are female, about 70 to 80%, but I think this is pretty similar among the 3 groups. Their age, I think, is important to note because the bisphosphonate groups are definitely older. Their 71 was the medium age, and then for the group that underwent surgery, they were a lot younger, they were 56. So I think we have to take that into account. And there were actually, a lot of them were pretty much healthy. There's this sort of comorbidity index score 0 is like healthy people. And, we can see that for parathyroidectomy group, there were 70% of them were considered healthy. But even in the other groups, they had a large amount of them were considered healthy. But then I would point out to the sort of the index score when they were equal to or more. And then we can see that for the parathyroidectomy group, they're a lot less compared to the bisphosphonate group. So definitely parathyroidectomy group was younger, healthier, yeah. And then just going over sort of the baseline characteristics. So this is their medium calcium, and it looks like it's pretty much the same, 10.9 to 11.1. Their PTH level was a little bit higher on the surgical group. And I would point out to the sort of their medium baseline T-score that we can see the observation and surgical group, they have pretty much the same, minus 2.3, but the bisphosphonate group, they were lower, minus 3.2. And then when we see them dividing by normal osteopenia, osteoporosis, we can definitely see that bisphosphonate group, they had a lot more patients. 79% of the patients were in the osteoporosis group compared to surgical or observational group that they had only about 40%. So I'm going to be talking now about sort of the BMD changes, and they did have a group in women and then men. And you can note on the bottom of the graph that they had almost 6,000 patients in their initial group, but then in terms of BMD, they didn't have that many patients. So I think they said if we add that up, maybe not even 500 for the women part. And so the circle is observation, and we can see that it does decrease over time, as I think we all expect, which was also shown on the prior observational studies that we all know about. And then in terms of bisphosphonates, it's the square, and then parathyroidectomy is the triangle. And you can see that both of them are sort of about the same. There was probably a slight increase between sort of the time 0 to 2 year interval, but then we see that there's a decrease over time, even in the patients that receive surgery or treatment, which is a little bit different from the prior study. As you remember that I showed that they had increase in all sites after surgery. And they say that probably one of the arguments from the author is that, you know, this is a postmenopausal group, so this kind of goes along with sort of age-related bone loss that you expect in patients. And in terms of spine, you know, as we all know, these are 70-year-old postmenopausal women, so I don't think we can rely much on that. And in the other studies, they have also shown that spine is not as reliable. You know, even in the observation group, you know, you see that that's increasing with time. So I think we all know that that's kind of related to some DJDs in all these patients. So in all groups, they kind of had this different trend. And in terms of the men, you know, you can see the N numbers in the bottom. They're, you know, a lot smaller, you know, just 49 for observation, 13 for bisphosphonates, and 19 for parathyroidectomy. So they did had a little bit of a different trend compared to the women. And observation, you know, as expected, it did decrease over time. The bisphosphonate group, you can see that is the square, and then they did actually go up. But the parathyroidectomy group, you know, initially maybe there's some improvement, but then, you know, towards the end, you actually see that they're decreasing. And I'm not showing the graph for spine for men because, you know, they all actually increase. So sort of the same thing as with the women as we expected. So for their fracture risk follow-up, they had a median follow-up about 4.5 years. You know, they assessed about more than 31,000 persons years follow-up, and they had a total of 940 fractures. So I mean, it's pretty long time, but it's also a good amount of fracture, and they divided between 178 hip fractures and 762 non-hip fracture. But just remembering that non-hip fracture accounted for so many other fractures other than the spine fractures. And they had some loss of follow-up at 5 years, and some of them was due to death, 10%, and only a very small amount of them was due to sort of exit from the health plan. So I'm going to be just showing sort of their fracture rate, and they're shown in absolute risk difference, which I think I like absolute difference. And I'm going to be showing at 1, 2, 5, and 10 years. So you can see that at 1 year, the fracture rate for observation was, for hip fracture was about 4.3 per 1,000 patients. And then for any fracture, it was about 20-something events per 1,000 patients. And then if you compare at 1 year at patients that had parathyroidectomy, there's an absolute decrease by minus 2.8 for hip fracture. And then for any fracture, there's a decrease of minus 5.4. So, you know, for the hip fracture, it went from 4.3 events to, you know, less than 2 events per 1,000 patients. And one of the things that this paper, you know, they mention on, I think it's one of the things that they do mention a lot, is that for bisphosphonate, actually there is this increase in absolute risk fracture. You know, for hip fracture is 2.5, and for any fracture it goes up to like 12 absolute difference. So I think that's kind of striking. And then this kind of repeats over with the 2 year, 5 years, and 10 years. So for 2-year fracture rate at hip fracture observation, they had 10.2 events per 1,000 patients, and for observation at any fracture, they had, you know, almost 40. And then for parathyroidectomy, you know, they did have this great decrease, you know, by minus 6 for hip fracture and minus 10 for any fracture. And again, for bisphosphonate, we see this increase of fracture rate again, and this kind of repeats over, and we can just see that, you know, the fracture events, you know, as expected, they kind of increase throughout the years. And for the bisphosphonate, you know, there's this increasing fracture. For the surgery teams, they have the decrease in fracture rate. And then in terms of fracture rate, this is sort of the last slide. In terms of 10-year fracture rate for observation, initially was about 4. It went up to 55.9 on the observation group, and then for hip fracture and for any fracture went up to 200, which is it's pretty significant. And for bisphosphonate, you can see that comparing, in terms of observation versus parathyroidectomy, it goes from 55.9 to 20.4, and this is a decrease in 64%. And for hip fracture, and for any fracture, there's a decrease in 24% if you undergo surgery compared to observation. But then again, the bisphosphonate group, they show this sort of increase in fracture rate. And because, as we saw on the initial table, there was this difference in terms of patients with normal BMD, osteopenia, osteoporosis. They did a stratified analysis in terms of how the treatment affected the outcome, in terms of fractures, and they divided them in normal osteopenia, osteoporosis. And this is the table that I'm going to be showing. And as expected for normal BMD, there was barely any fracture. That's why I didn't even include it here. But then in terms of hip fracture, so this is again is absolute risk per 1,000 patients. So again, we can see that for parathyroidectomy, for patients that had osteoporosis, there is this decline in hip fracture. And this goes on for each year. And you can see that initially it is very small, but then it does increase a lot, by 10 years, the decrease in the absolute risk difference, it goes down by 45 events per 1,000 patients with patients that had osteoporosis. And then in the bisphosphonate group again, then you can see that there is this increase hip fracture in the osteoporosis group. And I just want to point out that, on the first year, it's not that much, it's 4.4 versus 5.5, and the absolute risk difference is only 1.2. But then as we go for after each year, it does increase by a lot, up to 19.2 difference at 10 years. And then for any fracture, again, we show the improvement with parathyroidectomy, and then worsening, more fractures if you're treated with bisphosphonates. And this is for osteoporosis and for osteopenia. And I think, it is pretty striking that for osteopenia and, osteoporosis, the increase in any fracture is, goes up to, there's a 70 something difference events per 1,000 patients. And then for the patients that underwent parathyroidectomy, just want to show that at 10 year, the osteopenia group, they had a decrease in absolute risk difference of minus 75. And their absolute risk of any fracture was actually the same as patients that had normal BMD, just showing that, osteopenic patients that undergo surgery, it basically reverses their risk of any fracture as defined by this study. So they did all their sort of fancy adjustment by treatment group, by sort of some confounding effects, and they found that there was no difference in the results that we just talked about. And they also noted that actually 67% of their patients met criteria for parathyroid surgery, but as we saw, only about 20% of them underwent surgery. So they also just wanted to raise awareness for how we don't, seems that it's not followed that often, the guidelines. And so in terms of limitations of the study, so it is a retrospective design of the study. It's so there's a non-random treatment assignment, and we don't have BMD data on all of these patients. It's only about 2,000 patients with BMD out of the 6,000 patients. And the way they defined it, primary hyperpara was basically based on serum calcium and serum PTH. So we didn't know about their 25-hydroxy level. We didn't know about medications that could be confounding with all of this. And as I mentioned before, there's also this part of patients that was censored out of the cohort. And the definition for hip and non-hip fracture is I think somewhat limited in the non-hip part. And there's always some residual confounding that you can still have, even though you make all the possible adjustments, it is just a statistical analysis confounding. And as I mentioned before, the bisphosphonate group, they were older, and they were also, they had worse bone, they had more osteoporosis, and they were less healthy compared to the surgery group. So the conclusions from the authors is that patients with primary hyperpara who have parathyroidectomy, they have a reduced risk for fracture. And those treated with bisphosphonates, they actually have an increased risk for fracture compared to untreated patients. And the beneficial effect of parathyroidectomy on fracture risk was concordant to the short-term increase in BMD that was observed in this cohort during the 2 to 5 years after surgery. And in contrast, the patients that had increasing BMD who received bisphosphonate, that did not translate in sort of decrease in fracture risk for them. So I think there is some limitations to the study, but it is a pretty large study, and I think there is some food for thought. So I think the question really is, bisphosphonates, they do improve the BMD in patients with primary hyperpara, but why is this increased fracture? And I think I just pointed out a few things. We do know there's limitation of this study is retrospective, but as we talked about yesterday, in this type of patient, how are you going to do a prospective study for fracture when the rate of fracture is so low? You're going to have to follow them forever with a really large cohort. And the prior studies with alendronate and primary hyperpara, they were for 1 to 2 years. And in those studies, they showed sort of a decrease in bone turnover markers, in that period of the study. But I think we don't know what happens with these patients, after that 2 years. And, and of course, also like bone quality, we don't know exactly what happens. And as these patients are treated with bisphosphonates, and we saw that at the study during this week that their PTH levels actually don't decline. So, I wonder if there's sort of any effect that this PTH can still have on the bone. And we know that with cinacalcet, they actually have the decrease of PTH with treatment, and you don't have that with the bisphosphonates. And there are studies that show the combination of these two therapies, but they're even more limited because, I think there are even smaller studies, and I don't even know their follow-up time. I think it's really, really just very small. So I think I would love to hear from all of you about comments about why this is happening. And I just want to thank Dr. Bill Zekin and the Endocrine Fellows Foundation for this sort of amazing 2 weeks here at the Bone Preceptorship.